Could we welcome to the stage, please, the next speaker? It's Will Gregory, please.
Well, good morning, everybody. Thank you to the organisers for the opportunity for me to speak. Can everyone hear me all the way at the back? Yeah, great. Thank you very much. So, my name's Will Gregory. I'm a consultant physiotherapist working at Salford Royal. I've just celebrated 20 years at the hospital, but I think about 5 or 6 of those years we were transferred onto a primary care contract. So, although I'm talking from secondary care, please do aware I have experience, and we'll talk a lot about the primary care management of this pain condition. So I've been asked to talk around the diagnosis of fibromyalgia, but also the management of it, and you'll see why that is topical in a moment. I've got no disclosures to report, and the first slide is just thinking about chronic pain and it being one of the most underestimated healthcare problems in the world today. I did tell you I was a physiotherapist, and one of my medical consultant colleagues has advised me to keep true to my roots. I should encourage physical activity when I'm doing these kind of talks. So I'd like you all, if you're able to stand up at this point. You can have a little stretch if you need to, but that wasn't the aim of this exercise. We're going to think about the prevalence of chronic pain in the community. And I'm going to give you some prevalence ratios, and I'm going to ask you to sit down if you think it's that ratio or less, and we will be left with people standing up who think it is more common, whilst those of you who think it is less common will have sat down. So, first number to think about, if you think chronic pain, it has a prevalence of about 1 in 100 or less. You can sit down now. Yeah, I've given you a clue on the slide, haven't I, with regards to underestimation. If you think it's 1 in 50 or less, you could sit down now. 1 in 20 or less. Yeah, thank you. Some of you are sitting down. I appreciate that. 1 in 10 or less. Oh, very good. I think you may have been primed on this, and my final was going to be 1 in 5 or less, so I think that should get everybody sat down. Thank you for bearing with me on that. So this is a meta-analysis from the Pain Journal 5 years ago. 10.6% prevalence of chronic pain conditions in a number of countries. If we pick up the McFarlane paper, he was based at the University of Manchester, just down the road at that time, and we're just slightly above that in a UK population. So 1 in 10 is the nearest estimate we can get there, so you can give yourself a pat on the back, which was, I think, about 80-90% if you got the correct answer. And what I've been asked to talk about specifically is the main role in my day-to-day job, which is fibromyalgia. And fibromyalgia is a subsection of chronic pain. So we have the larger circle of chronic pain, and fibromyalgia sits within it. And the prevalence on a survey of 5 European countries, this is a little bit dated, 10 years ago, suggests we're looking at between 3% and 5% prevalence of fibromyalgia. So 1 in 3 to about half of your chronic pain patients would fit the diagnostic criteria for fibromyalgia. This should be quite a bulk of your work, I'd imagine, if you're working in general services, and particularly if you're in MSK. So a quick definition, despite that, for those of you who are less aware. So we know that fibromyalgia is a chronic condition. Pain is widespread, and there's associated profound fatigue. The pain is described as diffuse, aching or burning. It's usually body-wide. It certainly needs to be in all 4 segments of the body to reach diagnosis, and it can change location. This is from the Fibromyalgia Action UK website, and it's got some really good resources on there. I'd recommend that for you and for your patients. And they mentioned that it can be more severe in parts of the body that are used more frequently. Fatigue-wise, it can be as mild as feeling tired, less energetic, or it could go to the extreme exhaustion of a flu-like illness, leaving some patients bedbound for prolonged periods. Fibromyalgia, the name itself is half Latin and half Greek, so even the name is a bit confused, but literally translated as fibrous tissue or tendons and ligaments, plus muscles being in pain. So the name doesn't quite tell us the full picture of what's going on, but it's the name that tends to be used these days, and perhaps 20 or 30 years ago became more readily adopted. So what is it like to live with this pain condition? Well, symptoms are variable. We know it's long-term. There will be physical impact. There will also be mental health impact. For almost every patient we see, there is chronic sleep deprivation. And, of course, there will be an impact on social and employment status, living with all of those limitations, most likely. So why do we need to diagnose this? And this ties in very well with the talk we've just heard from Jack, in that there are some conditions that we could diagnose, but should we diagnose? Well, the key piece of research here is a UK survey from a few years ago, and it looks at the impact of diagnosing fibromyalgia on primary care patients, and particularly with their healthcare resource use. So this was a wider group of people with chronic pain, a percentage of who were diagnosed with fibromyalgia. Now, prior to that diagnosis, the fibromyalgia subset had 25 visits to their healthcare clinicians and 11 prescriptions, compared to those who didn't go on to get that diagnosis having 12 visits and 4.5 prescriptions. So the fibromyalgia diagnostic patient uses twice as much of our resources in getting towards that diagnosis. We also know from that study that after the diagnosis is made, those visits sharply decline. There is better self-management, there's better understanding, and there's better acceptance of the treatment strategies I'm going to talk through. However, a slight caveat, within 2 or 3 years, those visits rose to the levels or higher. So this isn't a one-off visit to give the diagnosis and then off you go. It needs to be a bit of a general follow-up that keeps that ability to better self-manage this long-term pain condition. So, how do we diagnose fibromyalgia? I'm going to do a little vote for you now. You did stand up. We're going to do hands in the air at this point, if that's okay. So, I suppose let's start with, and I don't want to embarrass anyone, but if you don't have any strategy to diagnose fibromyalgia, perhaps you wouldn't mind just raising your hand now. Gosh, thank you, that's very kind. Okay, how about our 18 trigger points of fibromyalgia? Hands up for using that tool. Very good. Anyone heard of the 2010 American College of Rheumatology criteria for diagnosis of fibromyalgia? No hands in the air. And how about the 2016 update? Fine. Well, that means the next set of slides will be novel information for all of you, which is one of the things I'm here to give you, so that's great. So I think the first thing to say is the classic tender points of fibromyalgia, where you prod your patient on 18 different spots, that got thrown out in 2010, so 10 years ago, and yet I still get regularly referrals that mention the trigger points. They aren't thought to be all that helpful. The problem being that, firstly, patients can vary their report of how they feel when you prod them in that force, in those positions. And also the person performing the assessment, if they're not trained, there is a big variability in how it is performed and offered. More relevantly, this paper from Pain Journal, again, showed that a self-reported questionnaire for these people with potential fibromyalgia correlates pretty well with the tender point count. So the tender point count essentially has been superseded. And next question, what's it been superseded by? Well, firstly, the 2010 version of the questionnaire, which asks your patient to tick on a sheet whether they do or don't have pain on 19 points of the body. I'll show you a picture of that later, so I won't talk through it just yet. And then there's a symptom severity score. The first component looks at the 3 characteristic symptoms of this chronic pain condition: fatigue, unrefreshing sleep, and cognitive symptoms, and ask your patient to score themselves as no problem, slight problem, moderate problem, or severe problem. And then the second part of the symptom severity score, this is the 2010 version, asks the clinician to score somatic symptoms as to whether this patient's got none of them, a few of them, a moderate amount of them, or a good deal of them. And you may not be able to see on the bottom of my slide, there is a list of about 30 symptoms there. And working in this service in 2010, 2011, we had this questionnaire, and the patients had to tick how many of those 30 symptoms they had. Quite a lot of burden in completing that questionnaire, and also a potential resource for the patient to kind of tick off the things that they haven't got yet, but maybe they should be expecting to happen to them any minute. So perhaps not a great tool to be completing. So that led to a slight modification in 2011, and then crucially, here we are with the 2016 version. So you can see from the diagram, it does cover the majority of the areas of the body that we ask them to assess where their pain presents. The 3 questions remain the same with regards to fatigue. Rather than cognitive symptoms on our patient-facing document, we've got trouble thinking or remembering, and waking up tired, unrefreshed is the third element there. So there was quite a bit of science that went into the 2016 update, and when they had a list of about 30 symptoms, they worked down which 3 are the most important with regards to diagnosing this chronic pain condition, and they were pain or cramps in the lower abdomen, depression, and headache. So quite interesting that those are the 3 that scored highest as the diagnostic markers for this condition. And that's very much trimmed down the questionnaire that we ask our patients to do pre-appointment. So I'm here as an advanced practitioner, and hopefully that's a role that you are seeing in your local services, that there are non-medics taking up roles that might previously have been done by your doctors, and perhaps that is a model we'll see in the diagnosis and certainly in the management of fibromyalgia in the near future if you've not already progressed to that. I screened my list for this afternoon of 6 new patients I'm seeing today. 3 were referred by either the practice nurse or the advanced practitioner FCP. So we're getting a decent amount of input already from primary care clinicians who aren't trained in the medical field. Sounds wrong, doesn't it? Who aren't doctors, let's put it that way. So the first pilot of this came in 2017, and one of my colleagues up in Preston had a very good success with regards to screening and diagnosing this cohort of patients within rheumatology, but in a primary care setting. And now we're looking at core capabilities, roadmaps, and just recently Higher Education Institute guidelines for first contact practitioner roles in MSK care in primary practice. And we have written guidelines for that last document that are fibromyalgia and chronic pain specific. So this will be getting out there if it's not already out there. I'm not saying this has to be an advanced practice or FCP role or a practice nurse role. This could be performed by anyone in the team, but the big push is, should a rheumatologist be diagnosing fibromyalgia or not? And I suppose the first bit on that is there a concern of an inflammatory component? Is there an inflammatory arthritis that needs to be ruled out? In which case, of course, the rheumatologist needs to be involved. If you're confident there isn't an inflammatory component, then it's rather dependent on the patient presentation as to whether a one-off appointment in rheumatology might be helpful in that pathway, in them gaining some validation of their symptoms, or whether that's something that could be equally well supported in primary care services. So our work at Salford started in 2010, and then myself in 2013, looking at this cohort of patients. And what did we find in the first 3 years? Well, the majority of those seen were able to be managed by myself. That's in blue. We had 6 patients that needed transfer to the inflammatory arthritis clinic with concerns that were further confirmed in the clinic that it was an inflammatory or rheumatoid type arthritis. At that time I had a consultant medic colleague, and we referred 10 patients on to him, and then there was 4 that needed input from other specialities, primarily endocrinology for our chronic fatigue service, with chronic fatigue syndrome and fibromyalgia being very closely interlinked. So if that's a little bit on diagnostics, what do we do once we've made the diagnosis? Well, the role of our clinic is to provide specialist assessment, to initiate treatment, and to introduce this self-management strategy, or perhaps supported self-management is a better term for what we're aiming for. We will look at the questionnaires I've just described, so the Widespread Pain Index and the Symptom Severity of the ACR 2016. In addition, we find it very useful to do a HAD scale score, so looking at anxiety and depression levels will help partly with the diagnostic journey, but also with the treatment plan that you will make from there. It's fortunately the questionnaire of choice in our clinical health psychology department as well, so we are talking in the same language when we do refer patients across for talking therapy type treatment. The questionnaire I've shown you a couple of times already. This is the data we've got, and apologies, this slide isn't particularly easy to read, but in the red we're looking at the widespread pain score. These are 500 new patients who've come to our service in the last 8 years, and you can see it goes from people scoring 19 out of 19, every part of my body hurts, down to some people scoring 0, and perhaps the average is somewhere in the kind of 10 to 15 level. So quite a variability of what we see, and similar for our symptom severity that looks at the non-pain symptoms associated with this diagnosis, where we do get some scores of 0, this is in the blue by the way, and other scores that will go up to the maximum 12 there. There is a theoretical option to provide a diagnosis based on adding those two scores, which will give you a score out of 31. And there's a feeling that probably a score of 12 to 14 or more would allow you to make that diagnosis. However, this isn't a numbers game. We couldn't get a robot doing this and looking at the numbers and making the diagnosis. There needs to be a lot of clinical judgment and other components added into the questionnaire score to get to that diagnosis. But if we look at it from the data we've got from our last 500 patients, the majority do fit in that blue box. So it's a very diagnosable condition, and those referred in for assessment, the majority do indeed have the diagnosis, as we'd expect with that prevalence. Those below the box, they are probably chronic widespread pain rather than fibromyalgia, so in that bigger circle, but some will have been transferred, as I say, to other services for other diagnoses. Hospital anxiety and depression scores, so a score out of 21 for each of those components, with a score of greater than 10 being of some concern for potential need for talking therapies, psychological support, mental health input. And this is our data set. I think this is the first 150 or so we looked at. And again, it's up and down. There isn't a clear pattern that everyone diagnosed with fibromyalgia does have high levels of anxiety and depression, but there are some that do score very highly on that criteria. And we do these questionnaires prior to the appointment because they will guide how we then assess, treat, and come up with a management plan together with our patients. So I've just put a little orange background on there for those that did have scores high enough to require clinical health psychology support. And that could be your local community-based IAPT service. It could be more high-level support if required. And the numbers will help make that decision as to where they are best supported from that point of view. So those are the standard questionnaires. We've not adopted anything else, but I keep on talking about adding a third questionnaire. There's a balance of finding out more information versus questionnaire fatigue and timeliness and so on. But the best one out there, I would suggest, is from the Pain Toolkit team, and it looks at a whole different elements of how the pain impacts on you and scoring them from 1 to 5. So it's a really nice, detailed and patient-friendly option for better characterising the pain and thinking about how your management plan might change with that. So what do we do in the appointments? Well, I've put top of the list, building a patient-clinician rapport. And this is our advantage with our service, is that we get 30 minutes with our patients for their first appointment, which is a lot more than the average primary care GP consultation of, 7 minutes? So I think part of the reason we do quite well is we have time to invest in our patients and to hear their story and to validate the issues they describe for us. So we'll ask about how long they've had their symptoms, anything notable when it started, how would they rate the severity of their pain when it started, has it changed since then? There's a decent overlap of childhood trauma in relation to development of fibromyalgia at a later age. And I would say the community working in fibromyalgia are fairly split with regards to when and if you ask that question. I think in your first consult to ask somebody if they had trauma in their childhood can be difficult because it will bring up a subject that could be challenging for them to talk about, and it may also divert them to thinking that that is the only reason they have the symptoms and we are suspecting that it's all related to that previous trauma. So perhaps not something to mention in the first appointment, but something to pick up later on, or something that they may disclose as part of a thorough history. Current presentation, how are you doing today? How does it compare? Good day, bad day? And then any suggestions of an inflammatory presentation? Should we be pushing down that rheumatology specific route, looking at an inflammatory arthritis potential differential? Finally, family history. So does anyone in your family have a chronic pain condition? And particularly, what's their experience been of that journey? So we'll talk about pain, we'll talk about sleep, the quality of sleep, how long they sleep for. Is it non-refreshing when they wake up? Even if they get a decent night's sleep, do they still feel rotten when the alarm goes off? What medications are they currently taking? What's their understanding of chronic widespread pain, their understanding of fibromyalgia? As I said, is there a family history of this diagnosis? If so, is this a shining star that's given them an example of how to best manage and improve? Or is this somebody who's really struggled and your patient is sat there saying, I don't want to end up like auntie so-and-so or uncle so-and-so? And then what's their understanding of talking therapies, CBT, psychology, and indeed exercise for treatment of their pain condition? So in the classic pain literature, there's talk of the 4 pillars of treatment. It's not quite overlapping with what we do for fibromyalgia. So I've introduced 4 turrets of treatment for fibromyalgia, which is entirely my invention and probably complete rubbish, but bear with me on that. Before we get to that, though, there is a video I'd like to recommend, and I'm firstly not 100% confident of the IT processes here and also aware we're running a little bit late, but if you'd like to go in and look for that video on YouTube, it's Explain Pain, and it has this 5-fold description of how pain impacts in a chronic pain condition. It's patient-focused, it is Australian, so that's not a barrier for most people, but just to be aware, some of the statistics are related to the Australian population, and it's something that we use quite regularly to inform our patients as part of the consult. So 4 turrets of fibromyalgia treatment. So looking at education, exercise, sleep, and drugs as our 4 angles of treatment, I guess. So if we start with perhaps the most important one, education, well, we'd look at pain education, we'd look at diagnostic-specific education. There's a role for reassurance. We're looking at education by peers, so can we get these patients sat together in a room together to share stories, share hints, share tips? That could be via a community-based support group. It could be you're looking at group consultations in your service, and it certainly is in group education sessions that we run and other fibromyalgia services will run. So patient education-wise, what are we aiming to do? Well, we're trying to get our patients to voluntarily adopt new behaviours, and that's true across any diagnosis where we look at patient education as a core component. And it's worth thinking about where your patient is. So if we think about the level of activation, the patient sat in front of you will be somewhere between these 4 levels. And we probably all have very strong memories of somebody sat at level 1 and you give them the best consult you've ever delivered, all the greatest advice, and they look at you fairly blankly, and they come back a few weeks later and they've done not a single thing you recommended. And that isn't because you failed to hit the target, it's because the target was too small at that stage. This person is disengaged, they're overwhelmed, they're not yet able to commit to kind of a self-management or self-treatment strategy. So if you've got somebody at level 1, you may be wasting your time by throwing huge amounts of resources at them at that point. What do you need to do to move them up, to get them into level 2? Ideally level 3, taking action, or perhaps from their level 4, so maintaining their behaviours and pushing themselves further in the self-management or supported self-management that you've introduced for this new diagnosis for them. This could be where you look at talking therapies, clinical health psychology, for those patients perhaps with high or moderate levels of anxiety and depression, but that complete disengagement. Now, that disengagement may be just because they've struggled for a long time and they can't see a light at the end of the tunnel. It may be iatrogenic in that previous clinicians have been rather dismissive of their symptoms and not very helpful, and therefore they're coming to see you and thinking, oh, not again. It's going to be like the last time where they made me cry and it didn't help and I didn't get any better for it. So we need to dig into that as well and see if we ourselves can push patients up a level. So thinking about how we work with our patients, this is the spectrum of public participation. Are we there to inform? Are we here to consult? Are we here to involve our patients? Are we looking at a collaborative model? Are we empowering? So again, thinking about how we deliver our education post-diagnosis can be relevant to firstly where that patient is in the journey, but also how much power we can give them in looking at their long-term management strategies. And apologies, this is a very fuzzy slide, which I've copied from a previous conference, but it looks at the medical model, or at least the delivery in NHS services of these different elements of engagement for our patient groups in these kind of diagnoses. So, we probably all know that pain medications are surprisingly bad at managing long-term pain. And I think that message is getting out there to the general public, but there's a really interesting piece of research that came out on BMC Family Practice that looks at people with chronic pain and their response to that first consult with you. If you don't mention medications in that first consult, there is a potential that they will distrust your management plan because they think you're withholding something. And equally, if you don't promote non-pharmacological options before medications, then the patient will be in a position where they only want drugs and they don't want to listen to anything else. So it needs to be quite a broad initial consult to make sure we cover, yes, there are medication options, but they only work for about 30% of people and then only short term, so we need to look at other treatment strategies as well. Education-wise, we do have a group and it's been published with fairly good outcomes, although our attendance rates are moderate. Any group setting of chronic pain patients, you'll invite 20 people, 15 will arrive, and at the end of the 6 weeks you might have 10 or 12 there, and it's just that issue of what level of engagement your potential group participants are in, I think, that leads to that problem. Sleep-wise, so why is sleep so important? Well, we know that almost everybody living with a chronic pain condition, and particularly with fibromyalgia, sleep deprivation is a component of their presentation, and it's a bit chicken and egg, which came first? They're in pain so they can't sleep, or is it the chronic sleep deprivation that means them more prone to suffer with pain? So we know about 50% of pain patients will have sleep interruption, and that sleep deprivation in healthy adults will reduce pain threshold and indeed induce pain itself. You can predict how severe and how persistent somebody's chronic pain is by looking at their sleep, and we know that generalised sleep disorders will be more prevalent in pain populations. If we look at the patient story, when they're asked what's the most important thing to you, number 1, walking or moving about, number 2, pain relief, number 3, disturbed sleep. So it's right up there. And where's that gone? Oh yes, so the suggestion is people living in pain have about a 68% sleep efficiency. And you sit there thinking, well, how do you work that out? Well, these days you can work it out with your smart technology, and either your mobile phone placed under your pillow or some wearable tech on your wrist will pick up your sleep pattern. And I would say my experience, 9 out of 10 people this works fabulously for, and it gives us some really good data with regards to current sleep efficiency, but also deep sleep versus light sleep and regular waiting. So hopefully that's getting out there as an idea, and I would say more and more when I introduce this concept to my patients, they say, oh, I've already been doing that and here are my numbers. And this is useful to see where they are, but it's also useful to see, has the medication made a difference? Does it actually change the numbers on your data collection? So those who do sleep better in the yellow here tend to have less night pain, they have a better mood with regards to anxiety and disability, they're less disabled, and their beliefs about sleep are better, somewhat unsurprisingly. Conversely, those with poor sleep beliefs tend to actually come true with that rationalisation and do sleep poorly. I'm going to whiz through this a little bit. So there is CBT for insomnia, which is just becoming available across the country now. And it talks about various strategies that can be used that are non-pharmacological to induce a better night's sleep. We know that CBT is useful for patients in chronic pain conditions, but sleep hygiene CBT seems to be a little bit more useful from this data. Moving on to medications. So this is our Right Care Commissioning for Value Focus Pack. I don't know if any of you got this delivered. The last one I could find was 2016, but this is our data for Salford as a general primary care and secondary care area, and there we are in yellow, being almost 2.5 times the spend of the best 5 areas in the UK with regards to our back pain and musculoskeletal pain drug spend. Now that may be the particular social demographics of Salford, but it does tell us we have an issue with regards to drug use in chronic pain conditions, and the main culprit at that stage, this is 5 years ago, was tramadol on the top of the list there. We know that opioids are a problem and they lead to some very severe issues and clearly need to be withdrawn. So therefore, until around a year ago, we talked about neurogenic pain meds, but we're not going to talk about them now because the NICE guidance with regards to chronic primary pain that was released in April of this year is very clear in saying do not offer gabapentinoids, benzodiazepines, corticosteroid, trigger point injections, ketamine. I don't know anybody who might have been offering ketamine, but there we go. Local anaesthetics, non-steroidal anti-inflammatory drugs, interestingly, opioids and paracetamol. Now that's quite a decent list of previously used pain medications. So what are we left with? Antidepressants, amitriptyline, citalopram, duloxetine, fluoxetine, paroxetine and sertraline. Interestingly, nortriptyline is not on that list. And they should only be used in consultation with regards to benefits and harms. Now, there's a statement that came off from the Fibromyalgia Action UK group that said, look, this is what's happening. You're not going to be stopped immediately, but you will have advice to wean and reduce your opioids, your NSAIDs, and even paracetamol. And these other medications are the ones that are now recommended. Guidelines, not tramlines, so it doesn't have to be 100% adhered to, but it's certainly the way things are shifting at the moment. Briefly, if you want to think about choice of medication, we can look at what's happened in the US with regards to the FDA approval of medications for fibromyalgia, and looking at the bottom box there with regards to choosing your SNRI, they do have duloxetine as the one medication that has a tick there. There is a second SNRI that I've half blocked out because it's not available on the UK market. But duloxetine is generally our first choice outside of amitriptyline for those that are sleep deficient as their primary issue. And of course a weaned increase for each of those medications, monitoring for benefit and side effect. Just briefly to touch on exercise, we look at graded exercise, so starting off at a level the patient can tolerate and gradually moving up in consultation with them. It can be performed at home. For us, we do a gym group with it. We also have access to a hydrotherapy pool. Lots of our fibromyalgia patients like the warm water, the ability to exercise in somewhat reduced gravity. We have a community group exercise session that copies what we do in the hospital on a Thursday lunchtime. It runs on a Friday lunchtime, and once you've used up your allocated number of slots in the hospital, you then go to the community group that is funded from a very beneficial grant from Sport England. And then fitness tracking, I've talked about sleep tracking. Well, if they're using an app, they can also use it for step counting and seeing how that changes over time as well to increase and improve fitness levels. Guidance-wise, I've mentioned the NICE guidance that has been released. There's some really nice, more patient-focused guidance from Fibromyalgia Action UK. The Canadian Pain Society have some good holistic recommendations. And I think I'm a couple of minutes ahead of time. So briefly, one of the reasons I mentioned the turrets for treatment is, of course, if you're in a castle, you can open the drawbridge and let down to allow access. We are a tertiary centre for fibromyalgia. There's probably a continuum, like I said, of those patients that can be diagnosed and managed in primary care, those that might need support in rheumatology, and perhaps those that need a multimodal pain centre type setting, and it's a bit of a pathway along those processes. It is a bit shocking. This is a letter from a local centre to ours that says, unfortunately, we're unable to offer any physiotherapy for this patient because we don't offer treatment for fibromyalgia. They need to go and be seen at a different centre elsewhere, which is really quite a concern when it's such a prevalent condition. What did I say? Kind of 5% of the population will potentially meet diagnostic criteria here. So we need to get used to seeing it, get used to diagnosing it, and get used to managing it. And that completes what I wanted to say today. Thanks very much for your attention. And I'm very happy to take any questions. This is going to be exercise for our support team who are going to run around with the microphone if anybody wants to throw a hand up.
Can you just put that video link back up?
Ooh, somebody will put that video link back up for us, yeah. Sorry, I could have put the search item in there, which would have been a lot easier, but of course, yeah, take a photo. I think you're all mindful that if we run on time, we'll get coffee at 11 o'clock, so I'm going to respect that decision and leave you at this stage. Thanks very much. Oh, sorry, no, there's a question there. Sorry, I'm nearly.
Can you just give us some guidance on this graded exercise? The graded exercise and pain, in terms of what we can advise to give to patients, in terms of do they push themselves through pain, should they go up to the point of pain? Do you get my following?
Yeah, so graded exercise has some controversy around it within the CFS-ME world, and graded exercise therapy is not a good term to use around patients that might have overlap fibromyalgia CFS. But it is the term we're left with at this stage. We look at finding an exercise that the patient enjoys, which might just be walking around the house or an exercise bike or whatever. We'll try and identify what they could do on a good day versus what they could do on a bad day. You then find a midpoint and take 20% off that, and that's your daily budget, which you increase by between 5 to 10% a week to gradually progress levels with that in the absence of a flare of symptoms or something else that might interrupt. We look at a 5 days a week pattern, so you don't have to enforce 7 days a week of doing that level of exercise, but 5 days with 2 days off tends to be tolerable for most. And whatever exercise you do will be beneficial, so it's not one specific thing that's the best plan. It's something that the patient enjoys, is engaged with, and perhaps has a friend or relative that supports them in doing it.